Hey,
Oh, Tony, here's a clicker.
how do I do it? Just press on?
I'm assuming, yeah, the arrows.
Yeah. So thanks to the guys, Dylan, Quentin, for organising, for having me along, and I appreciate the opportunity to come and talk to everyone today. And just to let you guys know that it was all by communication by email when these guys organised it, so they'd not heard my accent before they asked me to come here. It's really not their fault. And before I get started with this as well, we just have to check. There's been a bit of a communication error with the food out the front, and we just need to check that no one's had more than one piece of cake. Yeah. All right. Yeah. Okay. So my name's Tony. I'm a mental health CNC from the Gold Coast in Australia. I work for Queensland Health, but I'm not representing the organisation at all during this talk. This is all my own experience. So I trained in the UK as a mental health nurse. I've been in Australia for about 16 years. I've worked across forensics, acute, inpatient, and I now work in the emergency department. So I essentially work as a coordinator. It's a fantastic job. Everyone loves it. I help the ED move patients and avoid the emergency psychiatric service getting too many referrals that are really not necessary. So I'm in this like neutrally political space. Everyone loves me, so I love the job. At the moment, I'm also doing a master's degree in psychedelic medicine, mind and culture with the University of Exeter in the UK. It's taught by some of the world's leading experts in the field, and it's the first university-accredited course of its kind in the world. So it's a massive leap forward for mental health. One of the great things about the course is that it's not only focused for medicine. So there are psychiatrists on the course, there are psychologists, but there's also anthropologists, there's theologians, there's a philosopher. So they really target this topic from, all of the angles that, something so complex demands, really, instead of boxing it into any particular specialism. So yeah, I'll move on and we'll go through this. Some people are probably wondering, how is this relevant to emergency medicine? Basically, my job exists in the emergency department. I work as a mental health coordinator, so, there is mental health in the ED. If any of you guys think now of, the term, frequent flyer, chronic presenter, you're probably thinking of a mental health patient, whether you're a paramedic, whether you're a doctor, whether you're a nurse. And essentially, the emergency department really acts as a mirror and, reflects all of the cracks in our mental health system. We have people turning up to the emergency department frequently with chronic treatment-resistant depression. You have personality disorders with self-harm. There's people with substance use disorders. And, unfortunately, these people keep coming back. They get referred through to the mental health team in the ED. They have an assessment. They go home and they come back to ED in 2 days, or the paramedics are, back out at the house. Why is that? We've got a mental health service. We've got all of these options available for people, and something's not working. These people are coming back. Something is missing, that we really need to explore and find a way to actually help these people. So just some statistics. I'm not going to focus too much on the slides, but in Australia last year, there's 310,000 mental health presentations across the country. That's significant. It's huge for the population. Most of those presentations feature substance use disorders, people with significant trauma, and a lot of them are frequent presenters. So in the Gold Coast, the presentations make up probably about 6 to 7% of all ED presentations, which it doesn't sound like a huge number, but when you look at the amount of resources that those people consume, it's far above and beyond what 6 to 7% of your physical health patients often will consume because of aggression, because of intoxication, because of the management that you guys have to put in. And that's really what makes this relevant to you guys, is that, changes in the system will massively impact, workflow for not only us, but you guys as well. So just some of the statistics there. Like I said, 26% of people come into the emergency department. It's associated with substance use disorders, suicidal behaviors, psychosis. The numbers speak for themselves. And I work in ED. I also work for mental health, but I know the opinion of the emergency department because I work in the ED. I know how, disenchanted you guys get with the mental health service when you're constantly referring people through for assessments and everyone's saying mental health are doing nothing. Nothing's changing. Why aren't they doing something? Why is this person not going to hospital? So, that's where I'm moving with this, is that, we need to be able to provide something that these people need. So why are we in this position? Why are these people coming back? What is the actual problem here? So mental health is a very young specialty area. Within a couple of generations, we've, closed down mental health institutions. We've stopped giving people ice baths. ECT's now gone from something that you can be administered without anesthetic to, a regulated treatment and therapies. There's been a whole lot of change over the last, 100, 150 years. We're a very, very young specialty. And with that brings, a lot of problems. So if you look at a lot of the medications that we use, for example, I'll just focus for the moment on the depression stuff. Most of the antidepressants that we use, we're still targeting the same mechanisms, the same pathways as we were in the 1950s. So just for a brief history, most of the antidepressants that we're using now was discovered as a result of the tuberculosis outbreak, when they noticed that people's mood improved. That kind of drew focus to the monoamine oxidase changes in the brain, and this whole theories around serotonin, MAOIs and stuff developed, and that's where most of our drugs came from. It's actually secondary discovery during the tuberculosis. And when you look at these medications that we're using, fluoxetine, citalopram, sertraline, venlafaxine, it doesn't really matter which one you pick. They all move to the tricyclics. Most of the studies, even the ones published by the pharmaceutical companies, not to, speak badly of the companies that are making these drugs, but the truth is, most of them come to market with an effect size somewhere around 0.3 to 0.4. And, for anyone that's not done statistics for a while, that's classed as it's a low effect size. That most of them don't even meet the moderate effect size before they can actually be marketed as an antidepressant and say that this is an effective treatment. There's multiple studies that have been conducted. For example, there's one by the Food and Drug Administration in the United States. And I think the statistics they're not on there, but the difference between the placebo group was, around 38%, and the antidepressant group was about 47%. So there was a less than 10% difference in the efficacy of these drugs compared to someone being given a sugar pill or a placebo. And that was not even considering the potential use for an active placebo that might cause some side effects. And, you could skew that data even more. How effective are these drugs? It's one of the things that we've got to look at. Why are these people coming back? What do they need? We're trying to treat something with medications, and we've reached this innovation plateau where really we've not moved along mechanistically much in the last 50 to 70 years. So, there's multiple studies looking at how the response rate to these medications. So the STAR-D trial was actually conducted in 2006. Initially, they tried to claim that there was a 57% response rate after multiple treatment levels. I think from memory it was 4 treatment levels. But actually, that was the document was reviewed, and what the outcome of the review was that actually, after multiple treatment levels, the response rate is probably about 37% with antidepressant medications. And, we can speculate, we can look at all the reasons that might be, but essentially, we're giving people treatments for a condition that doesn't seem to be responding as well as we might really want to in an ideal world. So we've optimized new medication. All the new medications that we use, SSRIs, we've included norepinephrine, we've moved towards mirtazapine that will, ride the histaminergic receptors and provide some sedation, so now that's better for sleep. But essentially, they're all doing the same thing. They're all serotonergic pathway medications. Moving on from depression, we look at substance use disorders. So again, about 26% of the presentations that are considered under mental health, are substance use related. That doesn't even include the ones that wasn't flagged as mental health. So there's actually more than that come under pure substance use without a mental health component. So that's what you guys on the front line are dealing with every day. And what are the statistics for the treatments that we've got available? I don't need to show you this data. You guys are very familiar with the pathways, the services that we've got for substance use. You know how effective what we're already doing for people with alcoholism, for amphetamine use disorders, for opiates. Opiates, maybe a little bit unique. We've got buprenorphine, we've got, methadone as treatment programs, but we have nothing really similar for, methamphetamine. Some marginal evidence that naltrexone might reduce cravings. Buprenorphine can be helpful for some people, even though it's opioid receptors and, not really targeting the same pathways. Clonidine might help. You know, it's a blood pressure medication, but, you know, we're just trying things, and we're not really getting the answers that we need. We're not solving these people's problems. And, you know, mental health takes this step back and, you know, takes the stance that, oh, well, actually, you know, these people really have to be responsible for helping themselves. And, you know, that's as far as we've got with addiction, is that these people are making a decision. We'll call it an addiction, but they have to want to stop. And really, that's where psychiatry is. That's as far as we've managed to get in, you know, the years that we've been dealing with substance use, which is disappointing, really. So, yep, there's nothing that I missed there, I don't think. So the average time for people giving up alcohol that people, you know, identified and meet the criteria for alcoholism, usually around 9 years, you know, before they manage to get off the alcohol. You guys already know the damage that's been done by that time, you know, liver function tests, you know, cardiac issues. And the other problem that we've got, you know, the amount of people, the trauma that we've got in society today, you know, for various reasons that, you know, we won't go into any depth with. But essentially, most of the people that frequently turn up to the ED with suicidal ideation, self-harm, you know, you guys, definitely at the Gold Coast, we have people that are turning up almost every single day between, you know, Robina and the Gold Coast campus. And they're referred for a mental health assessment virtually every time they come in. And they still come back tomorrow after swallowing cutlery or taking overdoses or, you know, significant self-harm, profound self-harm, you know, requiring staples, sutures, you know, extensive periods of time in the emergency department. Why? Again, what are we doing about it? Is what we're offering people, is it any better? Is it any better than any of the stuff with the substance use disorders? And if you actually look at the evidence, truthfully, and you guys already know that this is the case, how many times have people referred and done the DBT program? How many times have they been through the psychotherapy clinic? And why are they doing it for the 5th time? Has it reduced it? Is the frequency, is the intensity, has it even changed? Quite often not, unfortunately. And, you know, this is the profession that I work in, and, you know, the reason I'm passionate about this is because I just think that we can do better. You know, something else needs to be offered. So if we look at the statistics, for example, for DBT, and most of these studies are actually completed by people that, you know, obviously have a vested interest in their mode of therapy being successful. You know, there is bias, you know, with most of the research that we do, unfortunately. But the effect size, reasonably short-acting, short-lived, and the stuff that kind of does move into a more moderate effect size generally fades. You know, we're not very good at treating people's trauma, altering people's thoughts, changing their behaviors. You know, people refer through to the emergency mental health team and, you know, they want us to put them in the Thought Changer 3000 and make them think differently and make them act differently. And unfortunately, you know, we're dealing with behaviors that have been ingrained since this person was, you know, sometimes 3 or 4 years old. You know, we don't have the ability to do that. You know, psychology doesn't even profess to have that ability, and psychiatry doesn't either. But it comes under our umbrella, and we constantly take the referrals for these people that we know we have no solution for. So, you know, some psychiatrists, depends who you work with, you know, some people will trial medications. You know, there's marginal benefit for people with, you know, personality disorders, chronic self-harm. You know, perhaps, you know, there's some mild tranquilization and reduces behaviors or improves sleep, regulates mood, but essentially it's not much better than the other options we've got. So this is really where I hope and I believe that potentially psychedelics, you know, could actually provide some relief for a lot of these conditions. You know, the conditions that we have basically just spoke about, substance use disorders, personality disorders, you know, chronic depression. Is the person actually depressed, you know, or do they have, you know, chronic dysthymia, trauma, you know, but we can tick the depression boxes, which is why it's not changing. Who knows? You know, it's too complex to get into that. But the truth is that, you know, these substances have been around for thousands of years. So I'll just give a brief history before I go into the mechanisms of action and that kind of stuff. So if people think of psychedelics, and, you know, quite often the first people will think of, you know, is Albert Hofmann synthesizing LSD in, you know, the 1940s. But that's really not the beginning of the story. You know, there's evidence that psychedelics have been used in spiritual, you know, religious purposes for not even hundreds, actually thousands of years. You know, if you go back to philosophers like Plato, there's evidence that he was part of the Eleusinian mysteries where they consumed, kykeon. It's a barley-containing substance where they reported consuming it and experiencing visions and reaching enlightenment. This is, 500 years before the Common Era. There's a lot of association. There's artworks of, psychedelics and mushroom people, in places like South America that, some of it's dated back 10,000 years before the Common Era. And so these substances have been around for a long time. So why are they not around now? What changed? Historically, people have had access to these substances across, various societies and global communities and religions. And something changed. So, after Albert Hofmann discovered LSD, through his work on the ergot fungus, the first thing he did is he, took the medication himself. Some of you are probably familiar with Bicycle Day, maybe the, most medically significant bicycle ride in history. And Albert basically worked for Sandoz, and he sent out the LSD to psychiatrists. So the first people to take LSD when it was discovered were actually psychiatrists. And Albert Hofmann had no real reference for, how these substances were affecting him or how they'd affect anyone else. And so what he did is he sent them to psychiatrists, and he says, look, I think you guys should try this. This causes hallucinations, it causes delusions, it alters your perception, and I think you'll be able to understand your patients better. So the psychiatrists took the medication. They experienced exactly what Albert had told them that they would. They had paranoid delusions, they had hallucinations, they felt fearful. And during this time, LSD kind of slipped out of the labs into, the community, and there was completely different reports. People were going, actually, we're not having any of that. We don't feel fearful. There's no hallucinations. We don't think anyone's trying to harm us. We're actually having a really great time. And the concepts of set and setting, were born in that, controlling someone's mindset and the environment that they're in is remarkably important for how the experience is how the drug is experienced. So, if people think they're going to have a great time, connect with others, that really does happen. It's a thingy. So, the thing that changed with all that, it moved into this counterculture. You've got President Nixon trying to, send people to fight the Vietnam War. There's soldiers coming back from Vietnam with opiate addictions, and, the war on drugs began. The substances, were banned at the 1971 Convention of Psychotropic Substances and, deemed to have no medical value at the time. So they were the Category 1 substances, and that, that essentially put a complete stop to any of the medical research. At that time, when these substances were banned, there was approximately 1,000 published articles promoting the benefits for substance use disorders, for anxiety, for PTSD, all of this stuff that we're now looking at prescribing them for in 2026, under a medical model. But there was evidence that all of that existed, and they were banned as having no therapeutic value. That's history, that's truth, it's fact, it's all written into the documents. And if you actually go through it, the chairman, Paul Groff at the time, actually listed his name as having opposed the ban. And, MDMA, for example, was the first substance in the history of the United Nations to be banned without a unanimous vote. And that was due to pressure from American lawyers. So we've gone into a period of prohibition. These substances have not gone away. So they were made illegal, but communities around the world have continued to use them in spiritual, religious reasons. There are underground practitioners that have been providing these substances for people to the last 20 or 30 years, the same as every other drug that's ever been prohibited in history. The prohibition doesn't work. And so at the moment, we're kind of in the middle of this what they're calling the psychedelic renaissance. So, for example, in 2023, Australia has become the first country in the world to reschedule psilocybin and MDMA, and it can now be prescribed by licensed psychiatrists. The approval process is, still a bit shaky. They're waiting for the Royal Australian New Zealand College of Psychiatry to develop their training pathway so that it can be rolled out much quicker. And, there are a lot of barriers at the moment. For example, there's psilocybin's not available as a commercial product, and so it's having to be compounded, and it's approximately $16,000 for a dose, which is, extremely prohibitive for most people that are wanting to look at a trial. And, unfortunately, when you want to run a trial, you guys, I'm sure, have been involved in research throughout your careers. Who pays for them? Where does the money for these trials come from? And in whose interest is it to, promote the use of a substance like psilocybin for depression when you're making, $100 million a year from fluoxetine sales, for example? And, that's not to, move into conspiracy stuff. That would be a terrible business for model, even if you were selling cars. That's not a gripe against the pharmaceutical companies. It's just the way the world is. So as of 2026, there's approximately 87 people that have been given MDMA under the prescriber scheme in Australia, so it is expanding. And around 47 people have been given psilocybin, and the results that people are reporting is consistent with a lot of the evidence that was around in the 50s and 60s. So when we look at the thing, I'm not going to go through all this data individually, but if you these are some of the biggest studies that have been done kind of in the last couple of years, mostly by people that have kind of facilitated the teaching and learning of the course that I'm on, actually. There's a quite small community through the King's College London and Exeter University and the psychedelic research down at Monash University in Melbourne. But looking even just at some of the basic data, some of the comparison of psilocybin to escitalopram, they achieved a 70% response rate. Not complete remission, but approximately 57 people on the study reported remission from their depressive symptoms. And what's really important to remember about that, it's an amazing statistic by itself, and it overshadows any of the antidepressants we've got on the market at the moment. It really does. But what you've got to remember about this study is that these studies are only being allowed to be conducted on people with treatment-resistant depression. That's what it is licensed for. We're not giving it as a first-line treatment. We're giving it to people that have already not responded to multiple antidepressants. We're already treating the most difficult group of people and providing results like this above and beyond any of the antidepressants in a group of people that are not considered treatment-resistant and should otherwise respond to therapy. So, these statistics, they look profound, and when you look into the actual, data collection and the methods, they could improve significantly from here, if they're not reserved for people that are only treatment resistant. So, all of the depression scores across all the studies reduced. There are not a lot of studies, again, because it's very difficult to get people to fund these studies. And the methodology, actually, science is not really on our side with these types of studies. If you're going to test a drug, your gold standard of pharmaceutical trials, you use blinding. How do you effectively blind a study when you've just given them 25 micrograms of psilocybin? There's not many people in that group that are going to guess wrong and go, yeah, I think I probably got the placebo there. Yeah. And that's one of the feedback from the pharmaceutical companies. Oh, this research is not valid. You've not conducted an effective study. But science is only correct until the point when it's proven not correct. And the methods that we use to test things, should only be considered the most effective method and until we reach a point where that method is no longer considered to be effective. And in this situation, you're never going to be able to do it. So, rejecting trials and rejecting the data on the basis that you can't blind it and it doesn't meet your expectations in a situation where it's literally impossible, it does feel like a barrier that's being created really at the moment. But yeah, significant results for depression. Substance use disorders, very similar. Another problem we really don't have an answer for, but the data on all of these studies is pretty significant. So the first study up there, so the people that had participated had actually only had 2 doses of psilocybin and had an 83% reduction in their alcohol consumption. And actually, this was basically maintained at 6 months. This is not someone going and doing a 30-day detox and then going, yeah, I'm clean, I've only drank twice since I got discharged 2 weeks ago. No, this is a 6-month follow-up where the people are still drinking and their reduction is reported as 83% less. If we look at people with, nicotine addiction, typically much easier to treat, but most people have got a 10 to 20% response rate to nicotine patches. People go all sorts of methods of stopping. But if you look at the comparative studies of people, there was 80% verified abstinence at 6 months. Like, this is not taking a medication every day. This is not a treatment that you have to adhere to. This is a single or a dual administration. This is 2 doses of a medication. With continued abstinence at 6 months, you know, something has changed. Something is happening, yeah? So, you know, I'm not going to go for all these, but essentially the results are significant. You know, people from the West are traveling to South American and Latin countries. They're going to Peru, and they're going and engaging in these treatments because it's not available here. People are taking the risk. They're flying to Gabon in Africa to do ibogaine. You know, it's a substance that if you don't have cardiac monitoring, it can kill you. You know, people do die from it, but it's highly effective, like profoundly effective. People feel like they've been reborn. You know, they move away from substances, and they change their lives, which is something that we can't make people do at the moment. And unfortunately, you know, people are still flying to these risky places and participating in unregulated treatments. You know, essentially because our health service holds ongoing bias from a period of prohibition that was really, you know, not that well supported by evidence. Moving away from the mind stuff, so yeah, okay, you know, the research says it's good for mental health, but you know, what else can we use these substances for? So there's actually a couple of mood clinics in Australia at the moment that are looking at trying to trial psilocybin for chronic pain. So actually, some of the studies that have been completed have shown people will, you know, significantly reduce their use of analgesics, opiate pain relievers, people that have been on these medications for 5 and 10 years with genuine chronic pain. And, you know, they're able to have 1 or 2 doses of psilocybin, and actually their need for analgesia, their perception of pain is actually altered. You know, their identification with the pain, you know, the way that they feel it functionally impairs them, and their ability to actually think beyond the pain changes. People, it is becoming effective. There are pain clinics that now looking to trial it in Australia because of international research that is telling us that it works. So yeah, some of those people were 86% reduction in their opiate use. Significant. So the other thing that we've got at the moment, that this was within the last couple of years, so Dr. Ross down in Melbourne, who works at Monash University, they came and gave some treatment at the education sessions at the Gold Coast where I work, and they talked us through the study that they'd completed in palliative care. So, you know, obviously the fear of death and dying in palliative care, you know, is a problem. You know, people get referred for mental health assessments. You know, shall we put them on an antidepressant? They've still got 6 months left. You know, they're miserable. And the videos of these people that they showed us, I don't think any of the clinicians in the room that participated in this education were not crying. Like, we sat through the videos of these people's interviews before and after the treatment, and it was phenomenal. It was emotional. It was moving. You know, they sat there, they cried, and they says that the experience was so beautiful. Their anxiety was completely relieved, and they felt that, you know, their connection and their understanding of the world that they live in is altered, and actually they've got no fear of death or dying. And you know, it's overwhelmingly positive. You know, we're still in the process of ensuring people do start to have access to these substances. We're not there yet, but it's happening. MDMA, not a classical psychedelic, you know, doesn't work the same as LSD, psilocybin, mescaline, DMT. You know, they're all kind of 5-HT2A receptor agonists. But MDMA has also been approved in Australia. It's being used, you know, it's considered an empathogen rather than a psychedelic, so increases empathy. So the clinicians that I know that are working with these substances are saying that essentially it increases people's empathy, it makes them more open. They're more likely to interpret body language and facial expressions as being positive, and they're able to build the therapeutic relationship much quicker. People are open, they're honest. You know, they don't hold stuff back in therapy when they've been given the MDMA, and people are reporting that they're having breakthroughs with patients that they wouldn't usually expect to see until they've been engaged with them for 6 or 12 months. You know, it's profound. You know, the university I'm at has done studies with MDMA with veterans, and you know, there's a significant reduction in their scores, and you know, they're going to places in droves to try and participate in these therapies. So yeah, the data really does talk to itself. 0.7%, I've tried to standardize all the comparisons. It's obviously difficult with everyone's study, either using Cohen's or the Hedges for the statistical, but I've tried to kind of make them as even as possible so that you can actually see it side by side. But that really, they're all saying that there's a moderate or sometimes even a high effect size. So when we talk about psychedelics, all the stuff I've been going through, I'm generally focusing on LSD, on psilocybin, on mescaline, on DMT. They're all 5-HT2A receptor agonists. And how do they work? I've tried to keep this medical. There are other viewpoints on how these medications, how these substances do work in the brain. But I've kept this medical for you guys because I'm sure that that's what you'd prefer. So look, basically, we know from in tube studies and in people that these medications are actually causing changes in the structure of the brain, and it's viewable, it's imageable, we can see it. Yeah, it's not theorized like the serotonin theories and monoamine oxidase theories. It's actually we can image it, we can see it. So people are taking LSD and for several weeks and sometimes months afterwards, there's evidence of synaptogenesis in the brain. There's increased dendritic length and density. There's portions of the brain that are communicating after being given LSD for weeks afterwards that weren't communicating before they had that dose. And that's very much outside of any of the current theories that we're using to treat people for depression. It's completely way out there. And how is that working? What is this actually doing to help people? How is that helping? There are a lot of different theories, but essentially one of the most popular theories at the moment, Robin Carhart Harris and the other guys there. Essentially, people with a depressive illness, you create these negative expectations, these anxious pathways in the brain, and it's very easy for the brain to repeatedly use those avenues and pathways, but most of that perception, that self-reference, the self-understanding is all embedded within the ego, and the ego, in adequate doses of psychedelics can be dissolved. It's thought to exist within the default mode network of the brain. It's a salient brain network that becomes most active, when your eyes are actually closed, and hosts the ego. So when you're not experiencing external stimuli and you have to sit with your own thoughts and feeling, that's when that part of your brain is actually most active. And so being able to desynchronize that network and disconnect yourself from your own understanding and your self-reference allows the brain to create neural pathways and create different behaviors. And that's one of the theories. One of the other studies that Leo Roseman did, he's another person that is one of the prime lecturers on the course that I'm at. So they looked at the default mode network in the brain, and we've always been told that people take psychedelics and all these areas of the brain, they start connecting. And what they really expected to see on these fMRI studies was that they took the psychedelics and everything started glowing. The brain's glowing up and it's all connecting. And they did the studies and they saw the complete opposite. So they saw this dramatic reduction in activity between these networks. And essentially the understanding of how this is actually operating is that we've been thinking about the brain the completely wrong way. We think that historically the brain's been considered like a generator, but in actual fact it's probably much more like just a filter. And so when you're taking the psychedelics, you're not creating or generating more content. You're actually just reducing the amount of filtration that your brain's able to complete on all of the information that comes in. So, for example, you see the light waves in the room. Where does this color exist? The color only exists within your own mind. And, if you take psychedelics, your ability to interpret sounds, colors, waves, all completely changes. Your perception changes completely because you're not able to access that prior information. So, when the light waves become an excitation, it's transferred to the thalamus. The thalamus is not able to access the priors because of the relaxed filtration. And therefore, your perception changes because it's no longer able to use your old references that this is a solid object. The walls are not made of water. This is not hot to touch, etc. So, your brain has to re-experience all of that and create new temporary understandings of the world around you, which causes the perceptual changes. but also allows you to move through anxiety in a way because you're having to work through situations and thoughts and feelings in a way that you'd not previously had to, because your brain's able to basically just use the embedded pathways that it has done for a long time, which was why we see all these repetitive, ingrained addiction behaviors, you know. So yeah, that's one of the theories. So beyond the acute psychedelic effect, a lot of people, you know, they talk, oh, you know, are you talking about microdosing? And actual fact, there's the evidence for microdosing is quite limited, mostly anecdotal kind of reports, and you know, it's not very well supported by evidence. The people that report most of the benefits from psychedelic medicine have a full dose, a full 25 microgram dose. You know, you need to achieve the ego dissolution. You know, people have to have a full, what they refer to as a mystical experience. You know, it's really defined as an experience that you're not able to communicate into words. You know, you feel like you've experienced some kind of receipt of knowledge or an understanding of the world that was not given to you. You know, you've received it passively. And, you know, people that take psychedelics, you know, are not able to fully describe the experience. And that's actually associated with most of the positive health and mental health outcomes. So, yeah. So with the receptor pathways, I won't get too much into that. Obviously, glutamate is kind of activated. Some of the medications that we do use in mental health, but so you know, the BDNF and the mTOR pathways, you know, they're all associated with essentially protein synthesis. You know, they're all, by activating those pathways, that's, you know, the mode of synaptogenesis and dendritic growth in the brain. So looking slightly just at some of the non-medical understanding. Essentially, you know, since Albert Hofmann discovered LSD in, you know, 1943, it's kind of moved a lot of this kind of stuff into a medical domain. But in actual fact, philosophers have been, you know, writing and using these medications for, you know, hundreds of years, long before, you know, the medical profession. And, you know, we definitely in mental health ignore things like people's spiritual beliefs. You know, we ignore things like metaphysics. One of the dramatic changes that people experience when they take psychedelics is their understanding of, you know, their metaphysical viewpoints of the world. You know, how am I conscious? You know, how am I connected to the world? You know, is anything else alive? You know, these, you know, dramatically change when you take psychedelics. Most of the medical professions probably, you know, quite physicalist, that you know, you believe there's a brain and everything in your brain and your experience is all generated from some kind of electrical, biochemical process. You know, you've got things like dualism where people believe, you know, the spirit is separate to the body and, you know, when you die, your spirit goes somewhere else. Regardless of what you choose to believe before psychedelics, most people after psychedelics move towards a more panpsychist view of the world. Very similar to kind of animistic cosmology that you'd see over in the Amazon, where people feel that the world around them is alive. Plants, animals, you know, any other living thing has some sense of consciousness or even sentience, you know, no matter how basic it is. But for example, if you look at the palliative care pathways, you know, that's probably really what's altering people's anxieties. You know, they don't feel lonely, they don't feel isolated from their world. They actually feel like they're much more connected, not only to other people, but to nature around them. So yeah, perhaps in the longer term, you know, for now these belong in medicine, but you know, the kind of terms we use to describe people's experience, you know, hallucinations, if you're a psychiatrist, you know, that's not what you call it as a philosopher. You know, it's completely different. You know, perhaps these drugs are, you know, better placed in the world of philosophy or, you know, anthropological experience or the community than psychiatry, but, you know, I'm sure we'll adapt. And the other thing, the last thing for you guys really, obviously, safety is always a consideration. You know, I'd imagine that most people that have come here today, we've lived through, you know, 60, 70 years of prohibition. You know, drugs are bad, drugs are harmful, you know, this will kill you. Take some LSD and you'll, you know, might jump off a balcony or think you can fly. And, you know, actually, the research, the evidence for the safety of psychedelic substances is absolutely remarkable. So, you know, just some of the quotes here. So one of the studies, it looks at, you know, the therapeutic index, the toxic dose. So the toxicologist that actually completed that study says that, you know, psychedelics are so safe for the human body that they actually defy the basic principles of toxicology. You know, in terms of the therapeutic dose and the percentage increase you would have to take to cause any kind of, you know, organ damage or toxic state, it completely defies anything else that we use as a medication, you know. So the next one is it's looked at 214 trials, yeah? So most of the incidents that we consider people to experience from psychedelics with recreational use, you know, in an uncontrolled setting, but actually across 214 clinical trials, there was no serious adverse events or outcomes. You know, some people experience some anxiety, you know, they get some panic, you know, but most of these symptoms, they do fade. You know, there's some kind of, you know, there is this perception of this, you know, hyperperceptual pervasive disorder, you know, but the statistical likeliness of that occurring is like 0.002%, and that's essentially people that report continuing to have hallucinations, you know, long after they've stopped taking the psychedelic. And, you know, my personal experience, it's been people with, you know, likely a diagnosable personality disorder before the experience. So the other thing that people commonly think is that, you know, you're likely to become psychotic from LSD or from psilocybin. Again, it's a myth. You know, when people come in and they're intoxicated from alcohol, they're drunk, they're acutely intoxicated. If you come in and you've taken LSD or you've taken magic mushrooms, you're acutely intoxicated. That is not a psychosis. You know, it's a psychosis when the drug's been metabolized and you've still got symptoms and you're still paranoid, delusional, you've still got hallucinations. Extremely rare. There's a study that was basically completed in the US emergency departments, and I don't think I've got the numbers there, but it was across, you know, approximately 75,000 presentations, and the psychosis is actually not even listed as one of the adverse events that they dealt with during all those people's times in the emergency department. It was all intoxication and transient. So essentially, you know, with proper screening, these medications are extremely safe. You know, they are expensive. You know, they do take up a lot of time. You know, you need a couple of guides. You know, guides not the term that, you know, the service is moving towards using, but essentially you need 2 clinicians, you know, to maintain that person's safety for, you know, 6 to 8 hours. So it's costly. It's, you know, probably will end up in the private domain really rather than public, but and that's it. Yeah. Any questions? I thought I was off the hook there.
I probably have a worse accent than you, so I'm really sorry. So I have 2 questions actually. First is, in your opinion, how far out are we from adoption? Everything you've said is fantastic.
Yeah.
And by the way, for the amount of time they spend on the A&E, we could easily give them and cover that 8 hours because that's just a fraction of how long we sit on them.
Yeah.
Just a thought.
So look, they've been rescheduled. It's really waiting on the Royal Australian New Zealand College to get their program out for the psychiatrists. The uptake has not been fast, and, you know, the other thing we've really got to look at is, you know, at the moment there's compounding. The only way to access them is compounding for a pharmacy. They're charging 16,000 dose for a, you know, a 25 microgram dose of psilocybin. You know, these substances are abundantly available in nature for free. And that is a lot of money, you know, to be producing something. Somebody's going to do it. We've just got to wait for it to happen, and in the meantime, it's going to be expensive. Yeah.
Fair enough. Second sub-question, specific to substance use disorder.
Yeah.
In your studies, have you seen anything come up about GLP-1?
GLP-1? No.
No, you haven't seen any of that across here?
No.
Okay, then disregard. Thank you.
Yeah. But ibogaine probably at the moment is probably going to be the most effective for substance use. They're not, you know, going to be using it here certainly for the moment because of the cardiotoxic kind of effects in high doses. But the reports of ibogaine are phenomenal. Yeah.
Any other questions?